Good afternoon, everyone, and welcome to today's Recovery to Practice webinar titled Supporting Recovery in Acute and Emergency Settings. My name is Elizabeth Whitney, and I will be your host today. After a short overview of Recovery to Practice, we'll begin today's presentation. On behalf of the Substance Abuse and Mental Health Services Administration and the Recovery to Practice team, we'd like to welcome you all and thank you for joining us today. We have over 140 people in the audience already, and we expect that number will grow. I'd also like to thank our presenters, Thomas Joyce and Brian Bailey, for sharing their knowledge and experience with us today. A few details. At the end of the session, you'll be able to download a certificate of attendance that you can use to apply for continuing education credits with your professional association. And we have good news for you. This webinar and all of the webinars in Recovery to Practice Winter Webinar Series have been pre-approved for continuing education hours from NADAC, the Addiction Professionals Association. To qualify for these continuing education hours, you must attend the full webinar, complete a brief quiz, and the webinar survey. More information on this at the end of today's webinar. At the completion of our webinar today, an opportunity to provide feedback will automatically open on your screen. And please take a few minutes to provide us with your feedback. We really value it. Finally, if you've registered for the webinar, you will be emailed a link to view the archived recording. And this link will also be available on the Recovery to Practice website, where you will also find links to past Recovery to Practice webinars. This webinar series is hosted by SAMHSA's Recovery to Practice. The overarching goal of this initiative is to improve the knowledge and ability of the behavioral health workforce to use recovery-oriented practices every day. But what do we mean by recovery-oriented practices? In 2011, SAMHSA released a working definition of recovery and a set of guiding principles that incorporate aspects of recovery from both substance use and mental health conditions. SAMHSA's working definition of recovery in behavioral health is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. The 10 principles of recovery shown on this slide, along with the 4 major dimensions of recovery, home, health, purpose, and community, form a solid foundation for developing recovery-oriented lives and for building recovery-oriented services and systems necessary to support them. SAMHSA's Recovery to Practice initiative helps you turn these principles into workforce practices. Recovery to Practice offers a set of discipline-based curricula to promote understanding and uptake of recovery principles and practices. Developed by these 6 professional disciplines for educating their membership about recovery and behavioral health, these materials are adaptable for use by other disciplines and organizations seeking resources to build a recovery-oriented workforce. Links to these curricula are available at SAMHSA's Recovery to Practice website. And Recovery to Practice is now expanding its discipline focus to embrace multidisciplinary services and integrated settings. Those of us who work in behavioral health or integrated health organizations have opportunities every day to promote wellness and recovery. We can powerfully communicate hope for recovery and the value of self-care and wellness just in how we approach our work. Recovery to Practice can help you strengthen your recovery-oriented practice through free webinars, newsletters, and training and technical assistance opportunities. And we're thrilled that so many of you are new to recovery practice are here today to learn more about us. We hope that you will join us for the entire Recovery to Practice Winter Webinar Series, exploring recovery-oriented practices in crisis and emergency services. And we'll provide more information about what's coming up at the end of today's webinar. Many of us recognize that with crisis comes opportunity for growth. All too often, however, individuals and their families who face a mental health crisis experience fear, disempowerment, and sometimes even trauma. This 3-part webinar series today and for the next 2 Tuesdays will examine a number of ways to integrate recovery-oriented approaches into response and support services that help individuals experiencing mental health crisis. It will present models and approaches that exemplify the value of a recovery orientation in these crucial periods. So I'd now like to introduce our speakers for today. Joyce is the Associate Director of Recovery Support Services at the Providence Center's Anchor Recovery Community Centers. A licensed chemical dependency professional in the state of Rhode Island, he has worked in the substance abuse field in both residential and outpatient treatment since 2006, specializing in peer-to-peer recovery support services, opiate substance use disorders, and adolescent substance abuse. A person in long-term recovery himself, he is an advocate in both the recovery and homeless communities. Thomas is associated with the Governor's Task Force on Drug Overdose, the Rhode Island Drug Overdose Prevention and Rescue Coalition, the Mayor's Substance Abuse Prevention Council, Coventry Substance Abuse Prevention Task Force, and is a board member of the Rhode Island Communities for Addiction Recovery Efforts. Brian Bailey is an Assistant Service Manager of Psychiatric Services at Parkland Health and Hospital System in Dallas. He received his Bachelor of Science in Nursing from the University of Texas at Arlington and is currently finishing his Master of Science in Nursing at Walden University. Brian currently has over 12 years in healthcare in both hospital administration and nursing, with his last few years spent in emergency psychiatric nursing. Before coming to Parkland Health and Hospital System, Brian worked with Green Oaks Hospital, which is part of Hospital Corporation of America, and was also with Baylor, Scott & White. In addition, Brian is a member of the American Psychiatric Nurses Association and is an active voice for recovery to practice with his peers. Welcome to you both. Thank you so much for being here. Tom, you can begin.
Okay. Good afternoon, everyone. As Elizabeth said, actually, thank you, Elizabeth, for that great introduction. My name is Tom Joyce. I'm the Associate Director of Recovery Support Services at the Providence Center and Anchor Recovery Community Centers. And as Elizabeth said, I'm also a person in long-term recovery myself. Today I'm going to be talking about a unique program that we have here at Anchor Recovery, which is our Anchor ED program, which provides recovery coaching in the emergency room settings. The agenda today is we're going to have an overview of the recovery coach's role in the emergency room departments, some of the program operations, such as the scheduling, how we use some communication devices, documentation, and some of the supervision requirements. We're going to go through an overview of the referral process for recovery support and treatment, and probably go over some of the data that we've collected in our first year of operation, actually, and we're in the middle of our second year as we speak right now. So a little background. Anchor ED was launched in an attempt to reduce the overdose epidemic that was hitting Rhode Island in 2014. The founder of Anchor Recovery Community Centers was a gentleman named Jim Gillen, who is a true hero in the recovery community on a national level. And Jim was actually at the Behavioral Health Department of Rhode Island speaking of what kind of plan of action could actually happen to reduce, not really to stop what was going on, but to minimize some of the damage that was happening. And through a conversation with Rebecca Boss, who works with the Behavioral Health Department, and Jim, they decided to use some of the recovery coaching that was happening at the Anchor Recovery Community Centers and try to see if we used them in the emergency room setting, what would be the effect and what would happen. And at that point in time, Anchor ED was launched. What we do, Anchor ED actually utilizes peer-to-peer recovery supports in an emergency room setting. The time when someone overdoses is medically risky, but it also presents a unique opportunity at that point in time for that person to engage in some type of supports. Peer-to-peer recovery supports is recovery coaches within recovery themselves who share themselves at that point in time, in that point in crisis, to get a relationship with the person who just recovered from an overdose and try to engage them in some type of recovery supports. Prior to this, overdose recoveries, and in most of the emergency rooms in Rhode Island, part of the process was they would get medically stabilized and they were discharged with really minimal resource or any type of information that was going on. And they were not routinely referred to treatment or recovery support services. So, Anchor ED was created really out of a recognition that this was a lost opportunity for an intervention and to actually engage in that person at that point in time. As it said, sometimes it takes a tragedy to induce change. And the Anchor ED program is a prime example of really, recovery-oriented program that's put into action that seems to be very, it's effective, and we'll go through some of the data as we go on. The Anchor ED program, under this initiative, the recovery coaches are certified in the state of Rhode Island, and we'll go through that as the presentation goes on. But the recovery coaches are on call on a 24/7 basis. When the first year of operation, due to our funding, the Anchor ED program was only in operation from Friday nights at 8 p.m. to Monday morning at 8 a.m. Through some of the data that we worked on with the hospitals, that seemed to be the high utilization times that we put into action. As of September of this year, Anchor ED, we went 24/7. We are now in 9 hospitals in the state of Rhode Island, including Hasbro, which is our children's hospital, and Women and Infants, which is basically prenatal care. We're also, we have agreements right now pending signing for the other 3 hospitals in Rhode Island, so hopefully within 30 days we'll be in all 12 hospitals in the state of Rhode Island. I have to say, my recovery coaches are probably the most dedicated and passionate people that I've ever came in contact with. They're on call for 24/7. They're on 12-hour shifts, and they never fail to rise to the occasion. Come here. So, certified peer recovery specialists. What they do is they meet with the patient after 2 hours of being in the emergency room. Due to regulations, if someone survives an opioid overdose in Rhode Island, they're going to be held in the emergency room for 4 hours. Usually after the 2nd hour, we will get the call. Our coach will go in and basically engage. I mean, the first thing they do is they fill out some documentation, which we'll get as the presentation goes on. But at the point in time, the most important thing the coach does is form a relationship and bonds. I like to say the recovery coaches who work in Anchor ED program, they're actually that human touch in the emergency room at that time of crisis. They're an empathetic ear, they're compassionate, they're empathetic, and they have a unique ability to bond by sharing themselves with that person at that time, to engage and let them know that there is hope, that that you can recover, not just recover, that you can recover well. At the same point in time, the coaches will ask, what's their pathway to recovery? What are they looking to do? If they're looking to get into treatment, we will actually assist with the hospitals to do referrals to treatment, whether it be residential, detox, or recovery housing. At that point in time, too, all of our coaches go through training. They're actually trained the trainers in naloxone. So before anyone leaves the hospital, they are trained with how to administer Narcan. Some of the hospitals have worked with us to supply kits. If not, we will give them the information where they can get the naloxone. Rhode Island is unique. We have a doctor called Jody Rich who actually wrote a blanket prescription for the state of Rhode Island. So any Rhode Island resident can go to the local Walgreens, go in and say they want naloxone, and actually they'll be provided a kit based on that point in time. So also, at the same time, the recovery coaches also will engage with the family if that's what the person wants at the time. We provide support to the family. We'll give them some information on some support groups or train them in naloxone at the same time. And then we keep in contact with them. After the patient is discharged and the coach is there, the coach will actually follow them through. They will be in constant contact for them for the next couple of days until that information comes back to us at Anchor Recovery Community Center. If they want to continue engaging in recovery coach services, at that point in time, they will actually get assigned a new coach, and we will stay with them throughout the whole length of their recovery, the whole pathway. So, as I said before, the hours after an overdose are, it's medically risky, but at that point in time, there is a unique opportunity to connect with those suffering from a substance use disorder. What we found is that by just utilizing some simple skills of motivational interviewing, but actually just sharing your own story with that person at the time, letting them know that you've been there, there's almost that instant bond that happens. And, we provide a little bit of education at the same time. And like we said, as what we say, in Rhode Island, it's that, substance use disorders is a condition, but recovery is possible. And what we do at that point in time, that recovery coach actually sells a little bit of glimmer of hope to that person to let them know that they can recover and someone is actually caring for them. So how do we engage? But to be honest, it's the story itself. You know, when the coaches go in and share a little bit of themselves, there's that instant bond that goes on. They listen and they're present to answer questions that the person might have. You know, sometimes people just survive an overdose. You know, they're not really too sure what the resources are out there. You know, and I think just starting the conversation with that person and let them know what the options are is important, because a lot of them just think it's just one option. You know, that they just have to go to detox. But what the coaches do is they share their own story and they share their own pathway to recovery, and let the person know that, you know, whatever their pathway is going to be, we're going to support them with it no matter what it could entail. We're not, you know, we don't really say you have to go to one place or the other. We will make it, you know, we will make a quick assessment and we will actually let them know what our opinion is, but really that person's pathway to recovery is what they have to create themselves and what's going to work for them at that point in time. At the same time, if they want to talk to the family, we'll actually go out and talk with the family. You know, let them know a little bit about what the person is going through based on our own experience, and actually give them a little education on substance use disorders in general. I think at that point in time, the family, again, it's a unique opportunity to engage with the family and speak with them a little bit and let them know what's going on and let them know what the options are. Because I know from our experience is that sometimes the family members don't really have the information that's out there. They've done some research, but I think it takes a point in time to let someone know that, you know, what, based on their own experience, these are the options that we have. I think the more options we can give to a person and family who are in that crisis at the time, the better off they can make an educated decision of what's going to work for them. So there is a little bit of a difference when it comes to recovery coaching. As here in Rhode Island, we call them peer recovery specialists. You know, we're non-clinical. We're people in long-term recovery who our biggest strength and our biggest tool is our own experience and our own life experience. So we aren't clinical. So, you know, part of being in the peer world is that there's no power differential, which separates us from your counselor or really your sponsor in a 12-step fellowship. You know, a counselor, as I said here, primary preparation to academic studies and ongoing training and supervision. Our coaches do, based on our program here at Anchor. You know, there is some training that they have, but they do have ongoing supervision. So there is some similarities, where a 12-step sponsor will basically be a person in personal recovery, and that's their experience. You know, there is a power differential there. Recovery coach, like I said, it's their main tool, their shared experience. A counselor will have a treatment plan, which is usually agency treatment approach, where a sponsor, you know, anybody in the 12-step fellowship knows that the 12 steps are the basis of the existence. What we do is in the recovery community is that we use a recovery plan. This is made from, we actually partner up with the recovery at the time. They make their own plan. They create it. They own it. They take responsibility for it. And it's something that's reviewed constantly with them to gauge where they are in their recovery and how they're improving or what we could do to assist them. I think the biggest differential here is self-disclosure. In the clinical field, and being a clinician myself, it was always used very sparingly to disclose that I was in recovery myself and what my pathway was. A sponsor uses it often. The recovery coach uses it often, but we don't really worry about the past. We self-disclose and use it to benefit the person, but actually what we tend to concentrate on is our recovery today and where we are moving forward and what we do to keep our own recovery in check. We really don't go into the past that much. We usually go from this point forward. Location of services, you know, most clinicians will meet in the office and the sponsors in the community. In recovery coaching, we can do both. We will meet you anywhere you need. You know, one of the great things about the recovery community is that, you know, we truly do meet the person where they're at, literally, wherever it would be. We just started a new program here at Anchor that's complementing our Anchor AD program, which is we started a street outreach team that's kind of supporting the Anchor AD program. So we actually have a team of recovery coaches out there doing some almost like homeless outreach, but street outreach, in coordinating and bringing recovery support services to communities or populations that wouldn't necessarily engage at that point in time. So another thing that's a little bit different too is that, you know, based in the clinical world, the length of treatment is usually based on the insurance or the length of services there. Sponsor and 12-step fellowship is always open-ended. And recovery coach is the same way. As a recovery coach, will stay with you for the whole length of your recovery, no matter what it be. We just started at Anchor working with some insurance companies, but that's usually, as long as the person wants to engage with us, we will stay engaged with them for the whole length of their recovery, as long as they want us. So we talk a little bit about how recovery coaches can complement the recovery process and how it applies to the ER. So what we found is that, I love the word complement because it's exactly what we do in the emergency room setting. We provide a unique resource based on our own experience about what could work and what could not. Also, the recovery coaches, I always put the challenge out in Rhode Island that I think my recovery coaches have the biggest toolbox of referral sources in the state, just by the sheer volume and the relationships that we have built. We know who we're calling, we know the person who's going to pick up the phone. And based on the relationship and our referrals, it works very, very well with us. And sometimes in the emergency room setting, the timing is critical because you have a short window if that person is going to engage and actually engage in treatment at that point in time. So I'd like to talk a little bit about the spectrums of attitudes. This is very, very important in our recovery coach academies, and it is treating people as either objects, recipients, or resources. And treating people as objects is when we know what's best for them and we disregard what their wants and needs are. This happens quite often in people when they're first starting off and first disclosing that they have substance use disorders. A lot of times this could come from the family, where based on that you have a substance use disorder, that they know what's best for you. And that doesn't really work best for the person that's recovering at that point in time. Treating people as recipients. This happens, it's happened to me in my own experience too, is where you're invited into the process, and this happens usually with aftercare planning, is that you're involved in the process, but the outcome is already done there. There's been many times when, based on my own experience in treatment, where I've been brought into an office and say, we're going to go over your aftercare plan, Tommy, and I'd say, okay, this is where I think would be a good idea, and they'd be like, oh no, well, we've already discussed this, and this is where you're going to go. At that point in time, I had mixed feelings about who had my best interest at that time. And in the recovery community, specifically with recovery coaching, we try to avoid that at all costs. What we do is we treat people as resources. I think there's one expert in the room when you're dealing with someone who just recovered from an opioid overdose, and that's the person themselves. There's a respect that's given to them and asking them what they could do. Because more than likely, they've been through the system. They know what's going to work for them. They know where they're going, where they want to go, and they have a good idea what's going to work for them. And we found that by treating people as resources, they have an honest approach to where they want to go. As I always say, from someone in long-term recovery, at one point in time, I couldn't hide from the mirror. I knew exactly what was going on, and I knew exactly what needed to be happening in my life at that point in time based on my experience. So by treating people as resources, we use that as, one, a relationship builder, but also to find out exactly utilizing a resource that really has the most expertise in that person's life at the time. So I'd like to speak a little bit about, and these questions always come up when we talk about the ED program, is, what's different in recovery coaching in the emergency room setting compared to in our recovery center? So all the ED coaches, they go through a 30-hour recovery coaching academy, but they're also trained specifically for anywhere from a 6 to 8 hour course, depending on people involved and how many people we have in that session, specifically how to work in the ER. So in the ethics and boundaries part of it is the same rules apply working in the emergency room as it would at the agencies. We do hold the coaches even though we're non-clinical, that we look at 42 CFR, which is no confidentiality with the HIPAA laws. We're always respectful of the ER staff, but we're always there is not to be afraid for help. So we know we're visitors, we know we're visiting on a volunteer basis in the emergency room, and we know our limits. But I have to go back because actually I got a little ahead of myself. So we're going to go back to a poll. We actually have a poll that's going to be taken right now. And we're going to discuss some of the things based on your experience of what happens in the emergency room setting. I do have to apologize. I got a little ahead of myself. On what's happening in from your experience or in the emergency room departments. What are some of your follow-up after discharge or aftercare planning? So I'm seeing here that offered peer support in some. So I'm seeing here too is I think a good percentage is the person is expected to make self-referrals from a list provided. That happens quite often. Or actually they're meeting with a clinician, which I think is great. So ER staff is given an aftercare plan with treatment expectations to that person, which I think is great too. But I'm seeing a lot here that the majority of the practices is that the person is expected to make a self-referral from a list provided. This could be for a person who just really survived an overdose. At that point in time, based on their own fear and not knowing the people on the list. I know we found that through self-referrals, the person might make the call, but they're not going to be as honest. I think, just like anything else, our recovery coaches have experience with some of the facilities they're referring to. So we found that by actually assisting them in that referral process, we can give our opinions and let them give a little insight of what the treatment center they're going to is actually involved with. We can let them know it's going to be a detox. We can let them know what the facility's like. We can give them a little outlook of what it looks like inside, actually, and what the facilities are and some of the things of that nature. So I think it's interesting, though, because we found that in Rhode Island that a large percentage of it was doing the same thing of the self-referrals from the list provided, but we found, too, that from the self-referrals, the follow-up wasn't there. The people weren't really following up with some of that. Some of the referrals that were being made. So I'm going to move. Okay. So part of our training with the additional training we do for the Recovery Coach Academy and for the Anchor ED is that we have a very well aware of self-care. What's happening in the emergency room departments is a little bit different, as I said before, than what happens in the community center. So, we have some people some of our coaches are in long-term recovery and actually experienced overdose themselves, or they had a family member or a friend. So supervision plays a big key into keeping our coaches healthy, because if they're not taking care of themselves, they're not going to be able to take care of the people they're going to see in the emergency rooms. So there's a real, we're very strong advocates of self-care to make sure that coaches are taking care of themselves first, and realize how they're feeling after they meet with the person who recovered. So I think it's very important because, a good example of that, we had one coach who actually was there, and it was a couple of weeks afterwards, but she kept returning back to one person that she met with, and through some supervision that we increased, she's doing okay, and we gave her a little break from the ED program, which is well needed. So part of the Anchor ED procedures, we're going to go through some of the training, the orientation, data and documentation, as well as the supervision piece. I've probably touched on a lot of these so far, but we'll go through in a little bit more detail. So, actually, I'm going to go back, excuse me. So every certified peer recovery specialist in the state of Rhode Island goes through a 30-hour training, and they go through additional training with the Anchor ED to work in that program, but they also do 500 hours of volunteer work to get their certification. At that point in time, they go through an orientation to the ED, which is our expanded training that they go through. And a part of that training, too, is the documentation and some of the that they will be providing in the emergency room. What's most important is the supervision piece. So the supervision piece, it's mandatory they meet twice a month. One of those is in a group setting. And we also meet individually, and they also check in before and after every shift. So how it works. So it's it's a very simple program. The coaches will go in, they will identify themselves at the beginning of every shift into the emergency room. At that point in time, they introduce themselves to the charge nurse, and then they'll be on call for 12-hour shifts. When a call does come in, it comes into our answering service. that will go to the coordinator, to myself, and everything else. We will actually let the coach know that there's a call, and they will actually present to the emergency room within 30 minutes. At that point in time, they will check in, and they'll begin and engage with that person who just recovered. So it's a very simple concept. You know, once we get the call, we put them right in. We make sure the coach is there. And then actually we begin the engagement process, and we'll be there through the referral process, and we stay with the person until they're discharged from the emergency room. So I'd like to go over some data. So it's, you know, in our first year of operation, we saw 230 survivors of an overdose in the emergency room setting. So out of that, 193 survivors, 83% engaged in recovery supports after discharge. So that was within 30 days. They either went to treatment, met with a recovery coach, or a telephone recovery support. We're very fortunate that our Anchor ED program is connected to Anchor Recovery Community Center, which is, you know, we see 250 people daily through that center, so we have a place for them to go. Only 36 survivors declined support. But what I thought was best, the best data that we took out of this was that we only saw 12 more than once. So these were the frequent flyers that were going in multiple times throughout the emergency rooms, and we only saw 12, which was, you know, 5% were only seen more than once. So I thought was an amazing statistic. So we always, you know, go through multiple recovery support paths, whether it be, you know, clinical treatment or telephone recovery support, which a lot of people enjoy, which is somebody calls them once a week, recovery housing or recovery coaching. So impact on ED staff and operations. What we found, which I thought was very impressive, that we slowly but surely, by people sharing themselves and treating people with compassion and being empathetic in the emergency room, we changed the setting in the emergency room, we changed the atmosphere. We found that a lot of the times the emergency room staff were a little more engaging with the people that you saw multiple times, realizing that there was hope for them and there was actually some help, which is something when the program was created, we really didn't see that happening, but slowly but surely we changed the atmosphere in the emergency room just by one person sharing their experience with another, which I thought was amazing, which I think if there's one thing I have to give credit for is that my coaches are, as I said before, the most dedicated and passionate people I've met. And what they've done in the emergency rooms in changing that environment to somebody, it's nothing short of amazing. So right now I'd like to introduce my partner in crime for today, my co-presenter, Mr. Brian Bailey. So Brian, if you take over.
Thanks, Tom. Appreciate it. So my name is Brian Bailey, and I'm an assistant service manager at Parkland Hospital, as Elizabeth and Tom have said. And I'm going to talk to you all today about some of the things that we did with recovery-oriented care and how has it affected change with our patients in order to achieve better outcomes. But also the secondary effect that we've had has helped achieve better care to our patients by the way that we communicate, listening to our patients and their needs, determining what it is that they're wanting to happen and us not telling them what we want to happen. So the first slide here. How do we get recovery-oriented care for individuals who come to the hospital for acute emergency issues started with our frontline staff? The RTP approach was rolled out to Parkland Psychiatric Services back in 2014 by our director, Celeste Johnson. She not only helped to develop the criteria and the curriculum with the American Psychiatric Nurses Association as part of her doctoral capstone, but she was also one of the first trained facilitators. So we like to refer to her as our Florence Nightingale of RTP. So she was the one who rolled it out here at Parkland back in 2014. Soon after, our psychiatric service line clinical educator was trained as well as a facilitator, and we were able to incorporate the training into our new employee orientation within all of our newly hired psychiatric service line staff. Additionally, we had current employees cycling through that training as well. I see there's a question already popping in about how the program is funded, and Celeste is actually on the call today. She can grab your name, Diane, and let you know how we funded that program. Also, we were able to identify that a lot of our training was best done when we involved our peer navigators. having them there, providing their insight and their feedback during training provided a different level of understanding for our staff that was secondary to none. In addition to that, we obviously take time every day to reach out informally to our staff on the units and train them into recovery-oriented care. Currently, we're teaching about trauma, triggers, responses, calming strategies, the importance of peer support, helping others feel safe, inspiring hope, and impacting of our behavior and communication on others. We're challenging our staff daily to be more flexible and to meet our individuals where they are rather than focusing on nursing tasks. That's one of the biggest things that we do. Additionally, we're challenging the long-held beliefs and traditional practices by encouraging staff to focus more on anticipating and meeting needs of our patients, preventing escalation, early intervention, and obviously using non-physical de-escalation techniques when we can. Due to this training, though, I will tell everybody, we have seen a very nice decrease in our restraint and seclusion rates. I don't have those statistics for you, but I hope to get them in the notes when we get those out. Another interesting point is that our emergency department, which is the entry point for all of our patients here at Parkland, is currently implementing recovery-oriented care training to their new and existing staff. We believe incorporating this education in the emergency department will positively affect how we care for patients from the moment they step foot in our emergency department, and hopefully will be carried throughout their entire visit with us. And eventually, we're hoping to see this become a hospital-wide initiative, as we know mental illness and recovery can be on any floor and in any unit. So, you see a person in extreme distress is coming to our hospital and seeking assistance and is greeted by our friendly triage nurse here on the left. Let's take a chat poll. If any of y'all chuckled at that cartoon, I'm sure y'all have seen it before. I'm sure a few of you did, and that's okay. That's the reality that we're facing here at probably any hospital. Changing the perception before a person even walks in the door is our goal. Now let's look to the picture to the right. You're walking onto our old inpatient psychiatric unit, and this is what you were greeted with: the danger, high risk, risk for elopement. Again, we can take a quick chat poll if anybody wants to chat in there. I don't think that that's a very welcoming environment when you're trying to come into a hospital unit. It suggests that we might be going somewhere other than an inpatient psychiatric unit. So we recognize some of our environmental opportunities as well and attempted to make positive changes so individuals felt more welcome. And I'm going to show you a lot of the changes that we made here shortly. So the first component we looked at was our verbal communication. This is an area where we made changes, and I think it's probably one of the most obvious for anyone familiar with recovery-oriented care, or RTP, reminding staff and peers that these are individuals coping and dealing with their condition and are not defined by their condition. So a lot of people who are in nursing have heard the comments of, oh, the borderline is back, or she requires too much of attention, all she wants is this or that. It's not very therapeutic at all, and more importantly, it's not recovery-oriented at all. We engage all of our new psychiatric services employees to recovery-oriented care. For many of the staff, this is their first time they're hearing this message, and many times I hear from staff that it changes the patient-caregiver message dynamically. Asking, what can I do for you, or how can we help you this visit, opens up a dialogue. It makes our patients and individuals feel more validated. We aren't here to judge or criticize their life choices. We're here to meet them in recovery right where they are. It's their decision as far as where they want to go or what they want to achieve every visit they come to us for. The next area, obviously, is nonverbal communication. I'm sure this is not unfamiliar to any of y'all either. Nonverbal communication speaks volumes. Many situations can be eliminated or escalated by not even saying a word. We see this a lot in our psychiatric ED. This is extremely true also in recovery-oriented care when we give to individuals. We aren't asking our nurses to give out hugs to everybody, but we are often asking them to, do the simplest things like sit next to the patients at their level and meet eye to eye. The actions that their nonverbal actions are excellent complements to the use of verbal communication, and most everyone is already aware of that, and we already discussed that part. So. So here's some of the environmental changes that we've made on our units. We're going to pull up a poll here in just a second. We changed our environment. The original door, you see it on the left. It said danger, high elopement, risk for closed unit. The picture on the right, I think you can agree with the lighter door and with the signs removed, the danger signs coming off the doors. It seems like a much more inviting environment. I think we're going to pull up a poll. I just wanted to see if you could use some just words that describe how you might have felt coming through the doors on the left prior than coming to the doors on the right. I think, Michael, we have to identify the unit as a psychiatric unit. I think that might be, Celeste might be able to pop in there and reply as to why we had to keep the psychiatric inpatient unit sign on there. So, yeah, I think it does too. I think so, Patrick. I have to agree with you. It looks a lot better. It's certainly a step in the right direction and much more comfortable. So here's some more photos about the inpatient psych unit. We created open spaces, used bright colors, artwork, more comfortable home-like furniture. One of my favorite additions is we have a rocking chair. It's on that left picture between, like, sort of on the couches right there. We have rocking chairs so the people who like to pace can rock back and forth, which kind of gives them some comfort. Also, our psychiatric emergency department includes private consultation rooms, including an exam room. We moved into this brand new facility at state-of-the-art in August of 2015. All of our units are psych safe now, our inpatient and our psych ED, and they offer a lot of different features that we weren't able to offer at our old facility. Our inpatient floors offer private rooms with flat-screen TVs on the top floor of our 17th-floor hospital, which is very nice. The views are amazing. Our day room has a refreshment bar with snack fridge and 2 flat-screen televisions. We also offer 2 recreation rooms where we do arts and crafts and group therapy. Our management has really gone to great lengths to make these environments pleasant and comforting while continuing to maintain safety. The next slide is our psychiatric emergency department, which also underwent some environmental changes. With our move, we included some more comfortable recliners in addition of 2 flat-screen TVs. We also doubled in size, but only went up in census 2 patients from 18 to 20. So we gave them twice as much room to move around in while not having to stack people up on top of one another. We also added a comfort cart that our mental health techs push around the unit, offering snacks several times during their shift. It's made a huge impression on patients because they don't have to ask for snacks. They have the opportunity to proactively meet their needs, which is really, really great. And then my favorite part of our program here at Parkland is our peer navigators, which kind of brings us back to what it was that Tom does with the anchors in Rhode Island. Of all the points, the incorporation of peer navigation is our proudest. It was launched in May 2014. We employ 5 full-time peer recovery specialists known as peer navigators who are in recovery from their own struggles with substance abuse or mental disorders to assist patients diagnosed with these conditions. To date, 4 of them have completed state certification. The Parkland program also includes a clinical pharmacist and a social worker. In Parkland's main and psychiatric emergency departments, our peer navigators meet with patients who have been identified with possible mental health or substance problems while they are waiting to be seen by clinicians. In addition to helping patients feel more at ease by offering support and sharing their stories of recovery, our navigators provide information about peer recovery navigation programs at Parkland. Once a patient enrolls in the program and is discharged from the hospital, the navigators will call them weekly, providing recovery support, referrals to pharmacists for medication, or to the social worker for housing, transportation challenges, and other social issues. They also provide information about other available community resources. Our peer navigators also lead or co-lead recovery support groups in our psychiatric inpatients unit twice a week, which is really, really great. So that's all I have. If there are any questions for me, I'm going to give it back to Elizabeth.
That's super. Thank you so much, Brian and Tom. Your presentations were great. You both spoke I think really movingly about what, as Tom was saying, kind of a group of, small group of dedicated and compassionate people, the changes that you can make both in the lives of the people who are using services, but also in the systems that you're working in, the cultures within which you're working, and how critically important that is, as well as really honoring the unique and personal pathways for each person in achieving and kind of following their own recovery path. There are a few questions that we have, so I'm going to try to get through some of them. I'm hoping that Tom is here with us, even though his camera isn't on.
I'm here.
Great. I'm going to start with you because there are a couple of just very practical questions. So one is whether recovery coaches as part of your program are paid. Is that a paid position?
Yes, we're very fortunate. We're part of the Providence Center, which is a community mental health organization in Rhode Island. So they are, but the Anchor ED specifically, it's funded through the state of Rhode Island through behavioral health through the block grant, the Hampshire block grant. So the way that the funding goes, and actually the pay for the coaches, to be on call, they get paid $75 stipend to be on call for 12 hours. Every time they get a call to the emergency room, they get paid a $50 stipend. So they're per diem recovery coaches with us, but that's how their pay goes by stipend. But at Anchor Recovery Center, we do employ full-time and part-time recovery coaches.
Great. Thank you. Thank you. And does Anchor have any programs outside of Rhode Island at this point?
Not yet.
Okay.
But actually, it's almost on a daily basis. I'm working with another community. Just this morning, I was talking with somebody from New Jersey who was looking to do a similar program like Anchor ED, and we're always, always have phone calls around the country to try to help people out to get either centers going or programs.
Yeah, I'm sure that's true. And we'll be hearing about some other interesting peer programs later in this series as well. But another question that I'm going to start with you, Tom, but that, Brian, a different version of it for your organization, it has to do with disciplines working together. So there were a number of questions about how other disciplines kind of fit in with the programs that you are discussing. And I want to put that in this, in terms of this, is kind of, so Tom, as you started to create the Anchor ED program, how did the other ED staff, did they have concerns? What were the concerns? How did you address them? And ultimately, how do the disciplines work together? Because it could be argued that some of the roles that the recovery coach are playing would be roles that would be typically held by a different employee, a social worker, or a discharge nurse, something like that. So how did you negotiate all of that?
I think a lot of it was a lot of time spent talking to find out what would work in the emergency room. So I know some of it, HIPAA was a main concern. Immunizations were a concern. So part of being with the Providence Center, we're also part of Care New England, which is a hospital group in Rhode Island. So all the coaches got fully immunized. We trained them with HIPAA. We went through the paperwork that the coaches would be using, and we went through the training. So it was slow at first. But as the coaches went in, as we started working the relationship, the hospitals realized the value of the peers and in the training that we put into them. But some of the barriers were exactly that. The interaction, that we were complementing, not replacing services, and mostly was based on the HIPAA regulations and confidentiality. So we worked with them, and but I think the main hurdle really was the immunizations in the emergency room. So that took the longest to get done, but we put all our coaches through the full immunizations for hospitals, and it's been going famously.
So it sounds like, just being clear, that it's not that the recovery coaches replace other staff, but that they're complementing the other staff, which I think is what you were talking about before.
Exactly. We want to be inintrusive. In the emergency room, we don't want to hamper anybody. We don't want to be a distraction, but at the same time, we want to make sure we're complementing the services and giving the support that's needed.
So, Brian, you talked about peer navigators in the ERs. Same question to you. How did they integrate into the work in the ER? How were they
Well, I wasn't here for the integration as far as back in 2014. However, I can speak to the fact that today, I mean, the peer navigators come through and meet with the nursing staff or the treatment team, which is a clinician, a social worker, and a nurse, and identify the patients that are in most need of the services, and then they meet with those patients as soon as they're here on staff. So those are paid positions as well for us. They're here, I believe, 24 hours a day. Celeste can correct me if that's wrong, but I believe we do have them here 24 hours a day. So someone is able to meet with them wherever they are, whenever they're here.
Great. Fabulous.
Yeah.
Some of the questions that are coming in about are how can we do what you're doing in our community? So you're making a real impact and a real impression in the work that you're doing. I'd like to put to you, Brian, a question about, we know part of helping people change their practices is kind of winning over hearts and minds. And what advice, what ideas do you have from the experience that you and Celeste have had at Parkland Hospital for what other people could do, either in an ER setting or somewhere else?
I think from the jumping point is really engaging nurses and clinical staff to change the way that they've been taught. It's just engaging them in a new way to approach patients from, like I was speaking on my presentation, with the verbal and the nonverbal communication, as well as just understanding that people are not their diagnosis. I think that's something that we're all working very hard to change, but, we have to fight years of mindset, which has been probably the most difficult, is, that oh, they're here again, but they're here again for a reason, and we're here that's what we're here to do, is to provide support and encouragement and recovery, not to judge. So that's probably the...
Yeah, so changing behaviors and
behaviors.
It sounds like, yeah.
Absolutely.
Tom, do you have any thoughts on that of how you change hearts and minds of people who are used to thinking in a certain way?
I think anytime that you have a conversation, anytime you change the language, should I say, I think using, the term substance use disorder, not addiction, stay away from the terminology of clean, dirty. And I think anytime you change the language, you change the community, you change the conversation. And anytime you change the conversation, that's where the magic happens. So I think it's just being role modeling, for one, in all interactions with people, and then advocating for that population also, and never missing a chance to educate somebody on that. These are conditions that are treatable, that people recover, and reduce the stigma that's attached to them. We found that in working in Anchor Edie, that there is some stigma in emergency rooms. And by changing the conversations and role modeling, the environment's changing. And I think what's happening specifically, I can speak from experience in Rhode Island, that the more the conversations are having about this overdose epidemic, the more compassion people are having towards what's happening out there, and then realizing that it's not just it's not a number. It's actually someone's son, someone's husband, someone's family member, someone's friend that's suffering.
Absolutely. Absolutely.
Sounds like that comment resonates with you, Brian, about...
It does. I agree. I
completely
agree.
Yeah. Personalizing
care is what it's all about.
And I think parity is it, but it's true. And we say all the time here in Rhode Island that if this was any other medical disorder, there'd be a national emergency that'd be out there. And we're looking at it now that it should be treated like any other medical disorder that's out there. There shouldn't be anything else. They should get the same treatment. They should same access to treatment, same medications, and really the same treatment, not as in medical treatment, but treatment by individuals.
So the way we regard them. Exactly, Tom. I agree. It's the way that we regard the patients is probably the most important thing. And if it was, if depression or any of their afflictions were equated to congestive heart failure, we'd all have a much different way that we would treat them and react to them. as opposed to it being a mental stigma that we have still attached to psychiatric disorders.
Exactly. We use the example all the time, like if I was a diabetic and I went and told my doctor I just ate a candy bar, he wouldn't refuse me treatment. But unfortunately, substance use disorder, that doesn't happen as much as it used to, but it is changing, which is a positive.
Right.
I think what both of you are modeling, and to bring it back to recovery to practice as well, is that we need to then help practitioners understand kind of what to replace that with, and how can we think differently, what's the language we can engage in that's different, what are the behaviors that will help us have a different outcome and to engage with people differently. And you've both shown that really, really beautifully. I'm going to ask one more question, Tom, and perhaps to both of you, but it's about whether you've been able to have, whether you attended to the cultural composition of who's on your recovery coaching team, or at Parkland the Navigator team, so that it matches the people who you're seeing.
It's a little bit difficult with the Anchor ED because when we get the first initial call, we just get really bare basics. So, but when they do come back to the Anchor Recovery Center, we're fortunate we have a wide variety of diverse coaches that we do try to match the recovery up to the coach that we think would be best fit, whether it be by gender, age, whatever they feel comfortable with. But we always ask the person, treat them as a resource, what kind of coach would you feel comfortable with? And they would let us know. We do everything we can to make sure they're comfortable with that.
And I would say the same thing with us. I mean, I think, like I said, we have 5 full-time peer navigators, and I think it's a very diverse group of individuals to meet the patient population that we see here at Parkland. That's obviously very important. We have a large Spanish-speaking population, so obviously we have access to that kind of the peer navigators, as well as the language lines we use and the technology that we use to be able to communicate with all of our patient population.
Super. Thank you so much. I have a feeling we could continue this conversation for a good long time, given the number of questions and comments that are coming in. But in the interest of time, I think I will thank you so much for the presentations that you've been able to give us today. So I would like to give you a special thank you, and if anyone has other questions or they'd like to get in touch with Tom or Brian, here is information. We'd also love to invite you to email us at Recovery to Practice. You can email us at the address here. We're excited about some of the webinars coming up. On January 26th, next week, we'll be talking about recovery-oriented community-focused responses to behavioral health crisis. And on February 2nd, hospital diversion and alternatives in crisis response. Both very rich discussions are planned. Please join us for as many as you can. Remember, if you can't join us, the webinars will be recorded and made available. So check the Recovery to Practice website for updates and archives of our past webinars. If you're interested in the NADAC Continuing Education Hours, please click on the NADAC link here on this slide, where you'll be directed to a page with the evaluation and a quiz to complete in order to receive your certificate. If you're not interested in receiving the NADAC CE Ages and do wish to participate in the quiz, you may download a certificate of participation in the materials download box near the bottom of your screen and complete the feedback opportunity that will load automatically on your screen following this webinar. And as I said, please do provide us feedback. It's very helpful to us in developing future webinars. So on behalf of SAMHSA, I would like to thank you all for taking time out of your day to attend today's webinar. We know you have busy lives and jobs, and we really appreciate your interest and your time. And this concludes our call for today. Have a great afternoon.
Thank you.